Hi, this is Nursinga. Today we're discussing cirrhosis and liver cancer and key concepts in chronic liver disease. Cirrhosis is a slow chronic destruction of liver cells that causes widespread fibrosis or scarring of the liver tissue. It's most often due to chronic hepatitis that's related to alcoholism or chronic viral hepatitis. Also, non-alcoholic steatohepatitis or fatty liver disease, it's referred to as NASH. Biliary atresia and genetic diseases can also lead to cirrhosis. NASH is an accumulation of fats in the liver that we see most often in our diabetes type 1, obesity, and patients with chronic hyperlipidemia. In cirrhosis, the damage to the hepatic cells is irreversible, and we see this kind of process of cellular destruction leading to this fibrosis or scarring, and then this formation of nodules surrounded by these thick fibrous bands of tissue. Blood flow then is altered because the liver is no longer kind of this spongy material that the blood can easily flow through, so there's a lot of kind of increased pressure, and tissue necrosis starts to occur. Treatment is palliative, so we treat the symptoms. The only real cure is a liver transplant. So once you get to the point of cirrhosis, the liver can't regenerate itself anymore, and you would have to get a new one. So looking at these pictures over here, we've got a normal liver versus a liver with cirrhosis, and you can see all those nodules. But then also in these little boxes at the bottom, you can see the one over here all the way on the right shows us a severely diseased liver with all of these fibrotic bands in between kind of the liver tissue and those nodules. And you can really kind of appreciate how almost like, if you think of it almost like steak, how like thick and grisly that would be and how tough it would be to get blood through there. Biliary atresia, as we said, is also a cause of liver failure and cirrhosis. And this is a really serious condition that occurs due to the obstruction of the bile ducts that results in cirrhosis of the liver in infants. So this is an inflammatory process. And we see this bile duct fibrosis, as you see on the picture here, where the bile ducts themselves are like congenitally deformed. Typically, this starts to present itself at about 2 to 3 weeks of age. So after that, pathologic and physiologic jaundice would have resolved itself in the newborn. And so you see kind of that typical liver's not working right kind of signs and symptoms, the dark urine, so the bili is getting backed up, the light colored stools, so the bili isn't getting into, or the bile at that point, but isn't getting into the stools to stain it brown, splenomegaly, so an increase in the size of the spleen due to kind of a refluxing or backflow of blood in the abdomen. Poor weight gain, so the child will experience failure to thrive and will not be hitting well on the growth charts. Pruritus, or itching from an accumulation of toxins within the body, and just this constant fussiness or irritability. The clinical presentations of cirrhosis, and we'll talk mostly about adults, but in children who have these problems, they would be the same, just in a smaller body. The complications of cirrhosis really depend on the extent of the tissue damage. Just like with shock, you can have like a compensated shock and a decompensated shock. We actually talk about cirrhosis as being compensated and decompensated. So in compensated cirrhosis, the liver can still perform the essential functions really without any major symptoms. But once we kind of swing over to decompensated cirrhosis, liver function is impaired with obvious signs and symptoms. And so these would be those kind of obvious things where you would say, hey, there's something wrong. And that includes things like ascites, portal hypertension, and the creation of esophageal varices, hepatic encephalopathy, coagulopathies, hepatorenal syndrome and loss of kidney function, and spontaneous bacterial peritonitis. So we're going to look at each one of these individually. As the liver tissue is replaced with those nodules in that fibrotic tissue, it creates pressure on the portal veins, leading to kind of an increase in the pressure in the vessels in the liver of greater than 5 millimeters of mercury. And this results in an increased flow, or kind of a redistribution of flow to other veins in the body. So this causes like these dilated varicose veins that back up into the esophagus, the abdomen, the rectum. So in the abdomen, this includes the stomach, but also the spleen. And so that causes splenomegaly. The spleen, remember, is responsible for not only filtration and acting as a lymph organ, but also for the creation and storage of thrombocytes or platelets, right? So if the spleen isn't functioning correctly, the body can't make thrombocytes correctly, and we end up with thrombocytopenia, so the patient then is at an increased risk for bleeding, and even a minor injury could result in a massive bleed because they can't create a platelet plug. In the abdomen and the esophagus, then we also have esophageal varices, and if one of those starts to bleed, the patient will have hematemesis, which is vomiting blood, or melena stool, or even kind of hemoptysis, where they cough up kind of bright red blood, depending on how high up the varice was when it ruptured. In the stomach, peptic ulcers or gastric ulcers can start bleeding, and that results in that coffee ground emesis or melena stool. In the intestines, there can be bleeding, and that results in maroon stool because the intestines are alkaline rather than acidic. So there's a different kind of denaturing process that occurs in the stomach with the gastric acids that makes it that black color. In the abdomen, along the abdominal wall, you get those spider veins, the caput medusae, that looks like kind of a spider or Medusa's hair around the umbilicus. And then at the rectum, we get hemorrhoids and bright red blood per rectum, or bright red bleeding with stool passage. Here we see esophageal varices through an EGD, so they're doing it like an upper GI, looking down, and they see these large dilated varicose veins in the wall of the esophagus. So as you can see, once they dilate like that, they're so close to the surface, these are very thin-walled. You know, even just eating something like sharp or scratchy, or coughing or vomiting forcefully could cause one of these to rupture. And when they do, they bleed very much like an artery. They're high pressure. They're, you know, again, very close to the surface, but because the valves are damaged, they just bleed, you know, very quickly and extensively. So again, we're going to monitor for bleeding. We're going to look for hematemesis, melena, restlessness, anxiety, thirst. So those would be signs of a hemorrhagic shock. Tachycardia, tachypnea, pale, cool, clammy skin, again, signs of hemorrhagic shock. Hypotension, delayed cap refill, metabolic acidosis, all signs of a hemorrhagic shock, right? And these are treated with what's called banding, and this is esophageal variceal ligation, or sorry, endoscopic variceal ligation, and that's where we go down with the endoscopy and actually put like a little band around one that's sticking out, and are able to kind of band it off, similar to like how you would band a polyp. Sclerotherapy, they inject a sclerosing agent into the vein and basically like plug it or kill the vein, for lack of a better way to explain it. But then that has a risk of like ulceration and further bleeding down the line. Antibiotics are given because infection is really common with GI bleeds. As a matter of fact, they say like 20% of all patients who have upper GI bleeds also have a concurrent infection. So antibiotics are pretty common. Propranolol, which is a beta blocker, the common name is Inderal, will help decrease the portal hypertension and decrease the blood pressure. And so that helps decrease the force against the walls and will allow those dilated vessels to kind of decrease. And then if they are bleeding, octreotide is the drug that is used kind of in the rescue situation to decrease blood flow to the esophagus as well as kind of through the gut. Fluid and sodium management is important to just overall decrease the portal hypertension and the dilation. So, restricting fluid and sodium intake. And then we used to use what's called a Stenckson-Blakemore tube, and this was a large tube that would go down the esophagus with a large balloon that inflated against the bleeding varice, but you didn't really know where it was bleeding because at that point in time endoscopy was not like readily available. So you just shove this giant tube into their esophagus and inflate the balloon and hopefully put pressure on the part that was bleeding, and that was kind of like the rescue until somebody else could take over. In the short term, an esophagogastric balloon tamponade has the potential to save the person until endoscopy can occur, but it also has potentially life-threatening complications of aspiration, accidental asphyxia, and esophageal perforation. So in the setting where endoscopy is available, that's usually preferred. So that you won't see the Stenckson-Blakemore tubes really used that much anymore. As a matter of fact, a lot of hospitals only stock them, like in the OR or in the ICU. Most hospitals, have gotten away from needing to use them at all. Ascites is a fluid collection within the peritoneal cavity. So portal hypertension, which we've just been talking about, also results in the formation of ascites, as you see here in this picture. So plasma, including the proteins like albumin and the globulins, is forced into the peritoneal space. Then that reduces the amount of circulating plasma in the blood, and it creates an oncotic pulling pressure within the abdomen itself, causing massive third spacing of fluid from the intravascular space into the abdominal cavity. So essentially the portal hypertension creates such a back pressure that it causes the plasma to leak out of the blood vessels and kind of like drip into the abdominal cavity. And in that plasma are proteins, but because the liver's damaged and it can't make enough proteins to replace what it's losing, we eventually end up with more protein within the abdomen than within the vascular space in terms of concentration, and then the abdomen has a greater oncotic pulling pressure and starts to pull water into the abdomen. And so ascites often starts out slowly, and then as soon as you kind of tip the scale where there's more protein in the acidic fluid than there is in the intravascular compartment, you then suddenly have like these massive fluid shifts. So this is vascular plasma, which is protein rich. It creates a great breeding ground for infections. We can get this subacute bacterial peritonitis, and it can progress to pleural effusions as well. So it can actually cross and go above the diaphragm. For that reason, most patients should be positioned with the head of the bed elevated at least 30 degrees to prevent the fluid backup and to allow expansion of the diaphragm. But you don't want to sit them up too straight because then the abdomen will be pushing back up against the diaphragm and they won't be able to breathe. So somewhere, about 30 degrees is usually preferred. Any volume greater than 500 milliliters will cause an increase in abdominal girth as well as abdominal pain and bloating. It's important for us to monitor fluid balance, respiratory status, and infection. So if the patient has, depending on the level of ascites, increasing the head of the bed again, so about 30 degrees, you could probably go up 45, 60 degrees even, will decrease pressure on the diaphragm, but you probably can't go like full Fowlers. You probably can't go like a full 90 degrees for especially somebody that has like as much ascites as we just saw in that last picture, because that would actually be kind of counterproductive. We restrict sodium to less than 2 grams a day, usually 1 to 2 grams a day, and then we use diuretics to increase salt and water losses. You want to measure the abdomen as well as doing daily weights. So daily weights still remain the best monitor or measure of fluid balance, but measuring the abdominal girth is important as well. So you will always measure that with the patient as flat as possible. And you measure the largest diameter at the end of exhalation, which is usually just above the umbilicus. And be sure to mark with a skin marking pen on the flanks and the top of the abdomen where you measured, so that the next person can consistently measure the same diameter. The treatment for ascites includes TIPS procedure, which is a non-surgical procedure where they go in, it's an endovascular procedure. They go in and they place what's called a transjugular intrahepatic portosystemic shunt. Right, so they go in and place the shunt, which is seen here in this picture, into the liver, and it bypasses part of that hepatic vein or the portal vein, allowing for, and kind of like stenting it open, but it's allowing for a decrease in portal hypertension and therefore a decrease in ascites. So this is called the TIPS procedure. And then paracentesis is removal of fluid from the abdominal space. Normally, this is a picture of paracentesis. Normally, the fluid is a clear yellow fluid. It may turn brown if the patient has really high bilirubin levels. Often, liters of fluid are removed, but only in the acute setting in the hospital. At home or in a facility, like in long-term care facility, we would never have anybody remove large volumes at a time through a drain that they had in place. So what is the nursing role? First of all, this is usually done like in the ER, the OR, the ICU, someplace, not typically done like on a med-surg floor, but you want to make sure you have ultrasound at the bedside, so it's usually done under ultrasound for guidance to help make sure that we're not hitting anything vital. You want to make sure that consent is in the chart and that the patient understands the procedure, and then you want to obtain vital signs and a pre-paracentesis weight after they have voided. So you should have them void right before the procedure to avoid any injuries to the bladder. You want the head of the bed up again at about 30 degrees to help move the fluid into a dependent position. And then during the procedure, you're going to monitor vital signs frequently. Hypotension is a really serious problem because as we start pulling some of that fluid off, it creates a potential space for more intravascular fluid to escape to. So we want to monitor vital signs frequently to watch for hypotension. You're going to measure and record the amount of drainage that was collected, as well as document the important information about the fluid. So the amount, the color, and the clarity. You want to label and send any samples to the lab that the doctor wants collected if they've ordered for analysis. So that's not every single time, but if they're worried that it is infected, or like the first time they do a paracentesis, they may send it for analysis. And then after the catheter is removed, you're going to place a dressing on the site and monitor for bleeding and infection. The patient should remain on bed rest after the procedure, and then you want to weigh the patient after the procedure as well and document your pre and post weights. If a Pleurax drain is left in place with the plan to send the patient home or back to a facility with the drain, you want to teach the patient and the family or the care providers how to empty the drain and maintain the system. And remind them not to remove more than 200 milliliters of fluid at a time to prevent hypovolemic shock at home. We always have to keep in mind that they don't have the same monitoring equipment that we do. So while we might remove liters at a time, they shouldn't remove more than 200 milliliters at a time. And because they have that drain in place and they can do it frequently, you know, removing small volumes more frequently should be a good plan for them. So one of the complications of ascites, but also coupled with then doing paracentesis, is spontaneous bacterial peritonitis. So this is an acute infection that occurs when gut flora is able to make it out of the GI tract, kind of like through the wall past the lymphatic system and get into the peritoneal fluid. And this occurs because people that are sick like this have a decreased immune system. So it presents with fever, abdominal pain that's usually more diffuse, hemodynamic changes, so they look very sick, and then encephalopathy also is common. A paracentesis would be performed then to obtain and culture acidic fluid, a culture and sensitivity, and antibiotics. And we're looking for, you know, now something that looks cloudy or purulent. Hepatic encephalopathy is another potential complication of cirrhosis, and this is where the flora in the gut produce ammonia, and the diseased liver can't detoxify it as it normally does. So our liver typically removes ammonia from our body, but when it's sick, it can't do that. So we have increased amounts of ammonia and toxins now in the body. When we have increased ammonia levels, we see confusion, motor neurodisturbances, and if untreated, it could lead to seizures, coma, and death. So we classify the stages of hepatic encephalopathy into 4 stages. In the first stage, the person typically has things like sleep disturbance, mood disturbance, some mental status changes, even some speech problems. And then in stages 2 and 3, we start seeing asteriscus. So this is where they get hand flapping. If you have them hold their arms out with the hands down, the hands will flap. It's also referred to colloquially as a liver flap. In later stages, we'll see or smell, I guess is the right word, fetor hepaticus, which is liver breath, and that's kind of a musty, sweet odor. As they become unresponsive, you'll start to see things like a positive Babinski sign. So when you stroke the foot, the big toe will fan up and out, and the little toes will kind of curl inward. Remember that we typically see with end of life, like, you know, people who've had a massive stroke. It's normal in babies for the first couple weeks and then not again. And then, you know, muscle rigidity and seizures as well are possible. Care for the patient with hepatic encephalopathy includes maintaining safety, so seizure precautions as needed, and really checking that environment to make sure that it stays safe. Avoid protein overload because protein contributes to ascites as well as to the creation of ammonia. And then decrease bacterial or gut flora production of ammonia. So lactulose is one drug that we can use that can help, and the other is neomycin. And when you treat the offending gut bacteria, so you're treating because the patient is symptomatic, and the symptomatic part of it is the altered mental status. So it's the encephalopathy that we're treating. The presenting signs and symptoms are the confusion or mental status. So when we treat it, they should get better, right? So the way that we know if our treatment is working is not necessarily that their ammonia levels are improving, but that their mental status is improving. You want to correct any fluid or electrolyte imbalances. Lactulose causes diarrhea, which means that it could upset the potassium, the sodium, fluid and electrolyte balance. So just make sure that you're keeping an eye on their labs. And then remember to continue to supplement the fat-soluble vitamins as well as a B complex, vitamin C, and folate. Coagulopathies are another complication of cirrhosis. Again, we talked about the spleen, so splenomegaly can result in thrombocytopenia, which increases the risk of bleeding. Scarring of the liver, so the cirrhosis also causes, as we said, decreased bile production, so damage to the liver. Even just hepatitis can cause decreased bile production, which then decreases the ability of the body to absorb those fat-soluble vitamins from the GI tract, and that includes vitamin K. And vitamin K is critical for the ability to create or synthesize clotting factors. So in essence, when I have liver damage, it is as if I am taking Coumadin. So my PT and my INR are going to be elevated, and I'm going to have a decrease in clotting factors 2, 7, 9, and 10, which are exactly the same ones as if I was on Coumadin. At the same time, I am super high risk now for developing a hemorrhage because I don't have clotting factors and I don't have platelets. And I could even go into DIC. So what do we do for patients who have bleeding? Because all of these sites can bleed. They can hemorrhage internally, they could hemorrhage externally. They could cut themselves shaving and they could just start bleeding like crazy. So the big thing is noticing. So you want to recognize bleeding or the signs and symptoms of shock. The restlessness, the agitation, the anxiety, the pale, cool, clammy skin, the tachycardia, the tachypnea, right? Recognize those as signs and symptoms of hypovolemic or hemorrhagic shock, and then look for and find the cause and then treat it. Control any obvious external bleeding, right? Direct pressure, pressure bandage. If you can't control the hemorrhage, then you would go to a tourniquet from there. And then report your findings immediately to the doctor, especially if you suspect internal bleeding, then that's going to require surgery. And be prepared to administer things like vitamin K or FFP to help, replace those clotting factors. Vasopressin and octreotide also can help. They're vasoconstrictors. They can slow down bleeding. If it's an esophageal varice issue or a gut GI bleed issue, octreotide tends to be the drug of choice. It's also called sandostatin. It decreases blood flow to the gut through vasoconstriction, but it also suppresses secretion of gastrin, gastric acid, and serotonin, as well as intestinal peptides. And it decreases blood flow to the GI tract, so therefore it decreases the overall pressure in the portal circulation. So if somebody is bleeding in their GI tract from portal hypertension, octreotide is really the drug of choice. A significantly bad complication, these all sound bad, right? But a significantly bad complication of especially kind of end-stage cirrhosis is what's called hepatorenal syndrome. And this is where the patient has a rapid deterioration of kidney function related to impaired renal perfusion. And usually this is coupled with a GI bleed or encephalopathy, and there's just an overall problem regulating blood flow or perfusion. They will have acute onset of oliguria where they have less than 500 milliliters of urine output in 24 hours or less than 30 milliliters an hour. And they'll have an elevated BUN and creatinine. The mortality rate with hepatorenal syndrome is incredibly high, and the only way to fix this is an immediate liver transplant. So medical management for our patients with cirrhosis includes monitoring lab values, looking for those elevated liver function tests, the AST, the ALT, elevated bilirubin, elevated ammonia, the prolonged PT, PTT, INR, the decreased platelets, the decreased albumin. All of these things we would consider to be expected findings in the patient with cirrhotic liver disease. CAT scans, EGDs, ERCPs are all used to treat and diagnose different complaints or issues related to cirrhosis. And then liver biopsies also are done frequently to kind of assess for cancer or to look at the degree of cirrhosis. So we just talked about the fact that this patient is like critically high risk for hemorrhage, and now we're poking a needle into their liver, which is a highly vascular organ. So monitoring for bleeding is going to be our top priority. As once they're done, you're also going to put the patient on bed rest to decrease, activity and pressure and portal hypertension, and to put pressure to the biopsy site to help decrease bleeding. Surgery is really the only cure for cirrhosis. So surgical management includes a liver transplant, and liver transplants are becoming more common. You can receive a liver from a cadaver or half of a liver, like one lobe, from a living donor. In the case of the living donor, both the donor and the recipient will have regeneration of the liver. It just regrows in size to meet the demands of the body. So you can see that there's multiple different ways, like where they can take different portions of the living donor, either the right or the left, and how they can attach it to the patient, the recipient. So after surgical transplant, we need our primary goal is to monitor for signs and symptoms of rejection. Right, so that would be tachycardia, fever, right upper quadrant or flank pain, a decrease in bile pigment or volume, an increase in jaundice, and these might be seen within the first 10 days of transplant. On labs, you would see an increase in bilirubin, ALT, AST, alkaline phosphatase, and PT and INR. So all of the labs that would have been elevated when the person had liver disease would elevate again if the patient has acute rejection. Cyclosporine is still the immunosuppressant that we would use in this case. And remember that immunosuppressant therapy increases the risk of infection. So oftentimes these patients are put on a prophylactic broad spectrum antibiotic to help prevent infection in the post-operative phases. The patient with cirrhosis is at risk for injury and bleeding related to impaired coagulation, so monitoring vital signs, IV sites, and the gums and the skin for evidence of bleeding like petechiae, purpura, that's really important. They're at risk for fluid volume excess and fluid volume deficit, so monitor daily weights, abdominal girth, intake, output, assess edema and respiratory status, especially for increased work of breathing and crackles. They have altered nutrition, less than body requirements, so supplement their diet, restrict the sodium, give water as appropriate, and monitor protein levels. They're at risk for impaired gas exchange related to the ascites. Elevate the head of the bed. Again, like 30 to 60 degrees. Keep them in that range. Impaired skin integrity related to edema and pruritus. So they, if they scratch, they're going to open up their skin. Fluid balance is important. Positioning, offloading, turning schedule, as well as just good skin care and lotion. And then activity intolerance, schedule rest periods, and that's really important. As I said in the hepatitis video, the liver is responsible for the proper functioning of every body organ system. Cirrhosis also impacts nearly every single organ in the body: the brain, the heart, the pancreas, the adrenal glands, the kidneys. Causes portal hypertension, which increases, the entire GI tract is affected. Systemic inflammatory response, circulating leukocytes, so the whole cardiovascular system, bone marrow suppression, the liver obviously is impacted, and then the lungs. So let's end up by talking about liver cancer. Hepatocellular carcinoma is a primary liver cancer. Other cancers like colorectal cancers often metastasize to the liver as a secondary cancer. The risks for hepatocellular carcinoma include chronic hepatitis B or hepatitis C virus infections, heavy alcohol use, so more than 2 drinks a day for several years, cirrhosis, autoimmune disorders, hemochromatosis, NASH, which is the non-alcoholic steatohepatitis, diabetes. And it's important to remember that the onset is often insidious, related to underlying disease and the location of the liver. So the patient oftentimes has no idea that they have liver cancer. They're usually asymptomatic until it has progressed into the late stages, and then they'll start to complain of weight loss, anorexia, and weakness. Hepatocellular carcinoma is usually fatal within 6 to 12 months of the diagnosis because it progresses so far before it's diagnosed. Treatment, and oftentimes what's interesting is that a liver transplant is not curative because of the progression of the disease. So oftentimes surgery is not an option. But treatment includes things like hepatoarterial infusion of chemotherapy. Radiation could be added to help shrink tumors, but it's not effective on its own. Transcatheter arterial chemoembolization, which is called TACE procedure. And that can be done in combination with hepatic artery embolization. So that's what this picture is here. This is, they thread a catheter in, oftentimes through the femoral artery, and up into the liver. And then they inject these little beads into the blood vessel that essentially plug the blood vessel up and stop all blood flow to the tumor. So it causes cell death by blocking blood supply to the tumor in the liver. So then, if you cut off the blood flow, then the cancer would die. And then sometimes that's followed a few days later by this TACE procedure, where again they'll go back up through the femoral artery into the hepatic vessel, whichever vessel it is, and inject the chemotherapy directly into the vessel that the cancer is in. And this allows them to do like larger, more targeted doses that they couldn't do through an IV in your arm without really making you very sick. Radiofrequency ablation sometimes is effective. Cryotherapy, so freezing. Surgical resection is usually just palliative, so they might remove a portion of the liver if it's heavily diseased or a tumor. And then again, liver transplant is an option for some patients, but usually not, because usually the cancer has progressed too far. Nursing management focuses on pain management, palliative care, so treat the symptoms, assist with teaching, learning, and coping, and end-of-life care. And when a patient who has an end-stage liver process, whether it's cirrhosis or cancer, is progressing to end-of-life care, listening and being there and helping them cope and letting them know that they're not going to die alone and that they're not going to die in pain is probably one of the greatest gifts that we have to give. So to recap, the liver stores blood. It makes clotting factors. It breaks down red blood cells and bilirubin to form that bile. It metabolizes food and wastes. It stores vitamins, the fat-soluble vitamins A, D, E, and K, as well as iron. So an improperly functioning liver then puts you at risk for bleeding. It puts you at risk for injury related to confusion from that accumulation of ammonia. It puts you at risk for fluid and electrolyte imbalances, and it puts you at risk for nutritional deficits. Thank you for watching, as always, and please feel free to drop us a note in the comments and let us know where you're listening in from. We hope you're doing well here at the beginning of April 2020 and that you are safe. Take care.